Sure.
And you can't, you might as well not sell it because you could be possibly selling something that has some lead in it. Follow me? It gets to be nuts, and it gets to be very expensive.
Talk about silent clots. That's a fabulous book. Ladies and gentlemen, Dr. James Privatera has written the book Silent Clots, Life's Biggest Killers. This is a big revelation on the discovery of a clot. So many people die of silent clots. Talk about it. What made you write this book?
Well, I saw that a lot of people who came in and had chest pain and had headaches and cancer had excess clotting and other problems too, other chronic conditions like arthritis. And I realized there's a lot of literature out there, but as far as the emergency rooms go and as far as the general doctors, they weren't really evaluating for people for excess clotting.
How do doctors evaluate for clotting at this point?
That's a mess, and I'm going to point out why. Okay, let's talk about an emergency room doctor, because I'll talk about some actual cases. The emergency room doctor comes in, and he has chest pain. And I say, I look at him and say, Bob, yeah, you got angina? He says, no, I have arthritis. I said, well, why do you think you have arthritis? He says, well, as an ER doctor, I had all the tests to exclude any problems with my heart, and everything came back normal. EKG, stress test, echocardiogram, all came back normal, so I don't have any excess clotting. I said, okay. So I looked at his blood, and of course he had a big clot, and we gave him some fish oil, and 10 minutes later, his clots were gone, and his chest pain was gone. I said, sorry, you have angina due to excess clotting, okay? I gave him a picture of his clots, took a Polaroid. So he says, well, that's great, Doc. I'm going to take this back to my emergency room people and administration, and I'm going to inculcate this into my angina workup. I said, great. So he went back there, and he says, hey, I have angina. I don't have arthritis. That was a wrong diagnosis. And I want to inculcate this dark field evaluation for blood, for clotting, into my practice. And they said, sorry, it's not protocol. And that's about like saying that digging a ditch, if you're a ditch digger, using a shovel to dig a ditch, right, is not protocol. How absurd is that? Okay, and that's the bottom line. Is it's so ridiculous to say that. So that's what happened. And then, as you know, recently, my bookkeeper, Pat, she went in the weekend. She had chest pain, went into the hospital. After $15,000 or $11,000 of tests, they evaluated that her chest pain. The cardiologist looked at her and said, your heart is not your problem. So they told her maybe try some antacids. Well, she came in Monday morning with pain on her left side, and I said, well, let's look at your blood. She said, well, nothing's working. So I looked at her blood.
Now, when you say, wait a minute, when you say I looked at her blood, tell us what you did.
We're looking under the microscope, looking at her blood under dark field microscopy, saw she had clotting, okay, gave her fish oils just like the other doctor story, and same thing, her pain went away, her clots went away in 10, 15 minutes. And so no problem, see, but so this is, how many times is this happening throughout the whole world? See, it's ridiculous, isn't it? Because it's not expensive. That test would be, for a patient, is like $40, okay? So cheaply we can evaluate and treat, and also migraines, and also clots associated with cancer, clots associated with arthritis, asthma.
You mean there's a whole panel of different types of clots?
Well, they're the same clots, but I mean these same clots are associated with all chronic degenerative diseases. Okay? There's more. In other words, the word inflammation comes up. So inflammation and clotting go together. The clotting is part of the inflammatory process.
Is it a different paradigm, or has this been around for a long time?
Well, it's been around for a long time. It's just that I noticed that nobody's really writing about it, or kind of nobody's putting it all together, so we kind of put it together, and we taught doctors how to, to get this microscopic system, and we taught them, they'd come here and we'd learn, they'd learn how to do it, go out and do it in our practice. But still, most doctors do not do this.
Why?
Why? That's a good question. Is it a conspiracy because they want more people to have heart attacks and strokes? Well, I hope not. But whatever it is, I'm going to get into the cancer issue in a minute because it reminds me of the same kind of thing. Meaning, let's talk about, it's nuts, isn't it, that here's this doctor, he's an emergency room doctor, and they told him, no, you can't use the dark field, which used to be used for syphilis evaluation. You can't use it to evaluate people to see if they have excess clotting.
Because it's unfamiliar?
Well,
it's not standardized procedure?
But it's been around for a long time, the dark field. That's what I said. They used it for evaluation of syphilis, which is an old-fashioned disease. So every emergency room has the same equipment, basically, that I have. Okay? In other words, I went into Pomona Valley Hospital, and one of my lawyers had a stroke. I looked at his blood with their microscope and saw excess clotting, and I said, he needs heparin because he has excess clotting. Well, same old thing. They didn't do it because it wasn't protocol.
What is heparin?
I'm on the staff there, and I couldn't convince the neurologist or the internist to do it.
So what happened?
He went on to die. See, what I'm saying is that, it's like this wall of protocol, right? It's nonsense, but that's the way they treat you. So getting into the cancer modality thing, there's studies on, for example, breast cancer that were done at John Wayne Hospital. 663 women were evaluated and found that a biopsy for breast cancer is a bad thing.
I've heard that biopsies actually activate metastasis.
Here's the numbers. That yes, you're very true. That's very true. What happens is there's up to a 50% spread if you do a core biopsy in a breast. Now, so I've done this with patients. So the patient goes to the doctor and says, I've got a lump, but I want you to do an excisional biopsy, meaning a tiny lumpectomy. And the doctors fight this. They say, no, it's not protocol. Protocol is to do a biopsy. But doctor, here's the evidence. The evidence is it was done at John Wayne Hospital, and a 663-patient study showed there's up to a 50% spread of breast cancer if you do this. Nope, it's not protocol. So finally, this one patient talks this doctor into doing this. Okay, doing the So the doctor finally does this excisional biopsy and finds clear margins.
What does that mean?
However, there was cancer when they took the tumor, the lump, the tumor, and chopped it up on the laboratory bench. They found cancer, and he said, well, there's a 20-30% chance that it went to your left axilla, left under armpit, so we need to take all those nodes out. Well, doctor, wait a minute. Let me think about it. Let me pray about it. Okay, so she calls me up, and I said, why don't you do a PET scan, which is you inject radioactive sugar, and cancer loves sugar, so it'll go to the, quotes, hot spots. So that was negative. So the patient says, no, I don't want to take any, I'm not going to have any surgery. So after a year and a half, the patient went back to the doctor, evaluation was negative. So how many times does this, how many spreads of cancer, how many node dissections or removals can you prevent by just doing this way, doing the procedure the way I just delineated? And this is another thing that I'm just getting into all these things that I get into and get in trouble.
Well, I've actually been fired by 2 doctors for requesting that they look at new protocols, new methods, new knowledge that have been coming in over the years, and gave them ample time to review things. And when there was resistance and unwillingness to look, an unwillingness to get up to speed about the new things that are going on or information that has changed, and I realized it was going to impact my health, I had to confront them. And even though it was done in a nice way, it was done, and the fact that it was done These doctors said, I don't want you to be my patient anymore. My patients don't talk to me like this. And I said, most of your patients aren't involved in investigative research and don't know what's available to them in the world.
Another big issue lately is mammograms. Okay? Well, there's studies now coming out. They do thousands of mammograms. Let's describe what happens. They crunch the breast, and then they radiate it. Okay?
Right.
Now, a study came out a couple of years ago that the MRI, magnetic resonance imaging, far outperforms mammography. But it's $2,000. So why did they put this study into the New England Journal of Medicine, which is the most prestigious journal in the world? Then they won't do the test because it's too expensive. So they're pushing the same old radioactive junk mammogram, okay, that's old. It's been around like 50 years. No change.
I did an interview with Dr. Bill Coburn, who's pretty high up in the thermogram arena.
Oh, good.
And I have thermograms done by him where they...
Right, so there's up to... You mean Cockburn?
Yes.
Okay, so there's up to a 20% increase in cancer in some studies of thousands of patients of people who have mammograms.
But that information is not really widely known. It's fascinating.
Right.
And yet thermograms have been around for almost 30 years.
So has ultrasounds. Okay. They've been around a long time, too.
So what do the ultrasounds have to do with mammograms or thermograms? Talk about it.
It's when they find a mammogram is inconclusive, then they'll do an ultrasound.
I didn't know that.
Yeah. Mm-hmm.
How long has that been going on?
Well, that's been going on for years and years. And then that'll give them a better idea. But basically the mammogram, because you're adding radiation to a very sensitive tissue, okay, should be banned. That's my opinion and the opinion of a lot of other people. Which leads us to the next subject, which is very related, and that's depleted uranium.
Talk about it. How does it relate?
Well, it's another radiation thing. Okay, it seems like everything we do, even like we can even relate it to the scans. They now want to scan us, full body scans, because of this duped situation. Meaning this guy, I believe, was a dupe, and there's a lot of data on Infowars and other places that this so-called underpants bomber, right? And they had previously bought these scanners a long time ago. Again, these are ionizing radiation.
I don't understand how that could even be legal, let alone constitutional. Seriously.
There you go. It shouldn't be. But I mean, I certainly wouldn't do anything if they had to do a body search for me. Fine, I'll go through a body search, but I'm not going to subject myself to a total body ionizing radiation scan.
What is an ionizing radiation scan?
Well, that's what they are. These scans, these total body scans that they're doing on people to see basically a nude body are ionizing radiation.
But what is that? What does ionizing mean?
You have an ion. Ion, you've heard of negative and positive ions,
yes.
Right? Well, you're actually affecting the DNA. See? And ionizing radiation mean you're getting ions, okay? Well, there's negative ions and positive ions, but I don't want to get into this, except that you're affecting your DNA every time you get one of these radiation scans, okay? That's enough for this conversation.
Okay, so what about the depleted uranium? Talk about that.
So the depleted uranium, okay, so why is that such an issue? Because they're using them in all the wars. What do I mean all the wars? Iraq War, Bosnia War, Afghan War. They're using depleted uranium. Now, the problem with that word, that phrase is it's not that depleted. You start with 100% uranium. Okay, use it in a radioactive material. It's used in a nuclear reactor, and then what remains is called depleted uranium. It's 70% the potency of the original uranium. It's used because it's 7 times the density of lead. It's used as a hardener in shells